Okay, everyone. Welcome. Welcome. Thank you, everyone, for coming to our HIV and Haiti lecture. I would love to introduce our colleague, Dr. Willy Dunbar from Université Quisqueya, the Faculté des Sciences de la Santé, the School of Medicine in Haiti. We've been collaborating with Quisqueya for many years through Dr. Zervos' collaborations, Linda, and a few other of our Global Health Initiative faculty working in Haiti. Willy, he'll be giving the presentation on HIV. He's a faculty member in infectious diseases at Université Quisqueya and also a coordinator at the Centre Quisqueya, which focuses a lot on infectious diseases and HIV in Haiti. He's received his MD from Université Quisqueya. He's currently working on his MPH through a university in France. And we're really pleased to have him here in Detroit this trip. We're moving forward a lot of our projects, which is really exciting. So everyone, please help me welcome Willy.
Thank you very much, Dana. Good morning, everyone. So this is a great opportunity for me to be here in front of you to talk to you a little bit about my country and an important disease in Haiti like HIV/AIDS, because we have done so much about HIV, and from the very beginning of the discovery of this disease, Haiti was and is still in the middle of being concerned about this disease. So excuse me if you don't understand some word because of my French accent, but I think Dana can help me if I forget some words. So I'm going to start quickly because it's there is a few slides to present. So Haiti is in the Caribbean. This is the highland of Hispaniola. Haiti is here, and Dominican Republic is here. So this is Cuba and Florida. So this is where my country is. And it was one of the greatest Caribbean French colony, because they used to grow sugar cane over there to do sugar for all the world. And it became one of the wealthiest of the Caribbean colony, and with heavy importation of African slaves. And after, we had a lot of difficulty with a lot of changes of people because of slave need. But it became in 1804 the first post-colonial black-lead nation in the world, and it's declaring its independence on January 1st, 1804. But since then, we have had a lot of bad situation. We had currently, this is the poorest country in the Western Hemisphere, and we had about 30 years of dictatorship. And just after that, Haiti is still a country with a lot of political trouble, with 25 governments since 1986, and with 3 international military troops. We have a lot of insecurity, kidnapping, rape, random shooting of civilians. And for the economy, this is a country at war. Natural diseases, this is in the Caribbean, so we have a lot of hurricanes, a lot of disaster. And one of the major things that we have is the earthquake on January 2010, 7 earthquake, and over 300,000 people were killed, and some 1.5 million left homeless. But for the health system, it's the big issues in Haiti. We have about 2 doctors for 10,000 people. But after that, Haiti is still a great country. It is in the middle of the Caribbean, and we call it Haiti Chéri, like sweet Haiti, the soul of the Caribbean. The basic fact of Haiti, it is 10 million people with a median age of 22. The population is pretty young, and with a life expectancy of at about 63 years old. The hospital bed is 1.3 hospital bed for 1,000 people, and the poverty line is below 80%. It's about 78% people living with less than $2 a day. And we have some unemployment rate over 66%. So the determinant of health is AIDS. I can summarize it like this with demographics, some biological situation, like we need a lot of disease like cholera. We have a lot of bad situation, and since we have the population is very poor, like a lot of them like in the 20s, so this is the force of work of the country. So when they are sick, we have big problem continuing our activities. And also environmental, there is hurricanes during the summer and heavy rain, and the environment is very bad, so we are flooding like after every rain. Socially, it is a big issue in Haiti because there is no work, so people tend to have some bad actions to live. And economically, it's a very bad country. And cultural, it's rich culturally, but cultural also we have some negative aspect. For example, we have voodoo in Haiti. If one person is sick, sometimes they go to voodoo priest. And voodoo priest, they don't know well what they are doing. Some use traditional herb to heal patients, but some take a lot of money without doing anything. And institutionally, we have problem with health system and health coordination because of changes of government every time, and no plan, no development plan for the country. We have a big problem with human resources and coordination because a lot of good brain in Haiti leave the country every year to go to Canada, France, or the United States. So we have problem having human resources. So now I'm going to start with the AIDS part. We first discovered this disease in the 1980 with the report of the pneumocystis pneumonia in 5 gay men with the CDC on June 1981. And after we have some additional cases, and they started to publish some new journals, new articles, about it. But the question was, when might have they become infected? So on 2002, we have more person, and on a survey that they found that a lot of people with HIV, the risk factors was Haitian, homosexual, hemophilia, heroin. So the CDC called it the 4H club. So it was because some of Haitian were homosexual, some of heroin taker, but they were afraid to tell about it. So that's why they did one of the risk factors to get the AIDS, because it was difficult to understand it at this time. So they say Haitian is one of the risk factors. But at this time, the Haitian, they did a big demonstration at Chicago. They kind of shake the bridge of Chicago to tell the people that this is not.
Can I ask a question? Go back, I should know this, the last line. So the introduction of course, Haiti was one of the first country with HIV, but what was believed to be the introduction into Haiti? Was it from? How did HIV start in Haiti? Was it from healthcare workers coming from other countries?
How
did it start?
We don't know actually, but we believe that we have HIV from people coming from Africa. I'm going to tell that in a second. So in the history from 1984 to 1987, we had some good things coming with the xylophorin, from the isolation of the retrovirus to the approval of the xylophorin as a medication. And then also, like you can say, in the US, we had a fatal mortality rate throughout the month after diagnosis, some opportunistic infections. So this is in the United States from 1981 to 1987. And then also for the epidemic, we started PCP prophylaxis in 1988, AZT for prevention of mother-to-child treatment. It was AZT, and then after in 1986, we have heart in developed countries. But after the conference in Durban in 2005, they started to fund undeveloped country to get free ART. So the dynamic of the HIV infection, I'm not going to stay on this for long because it's critical, and I know that you are all doctors, so you understand well the dynamics of the HIV. So when HIV enters the disease, it goes to the CD4 T cells, and it's break kind of your immune system. So since it's about a chronic disease, it may take long to starting to have some clinical signs and symptoms. But all of the things is play with the immune system, with the CD4 T cells, and with the viral load. And then after a few years, it depends on the person because there is also some long-term non-progressors. So the person starts to have some OIs, and after if nothing is done, we will have the death. The origin of HIV, we don't know well yet where is it. There is a lot of discussion. I think after this presentation, maybe some of you can share with us some good terms because I can say that for me it is not clear. And polio vaccine in Africa, maybe from polio vaccine in Africa, they were giving polio vaccine with one needle for many people. 1981 maybe from chimpanzee. And before we don't know, and what about now? I hope after this presentation maybe you can share your thoughts about it. And for the transmission mode, we know that it is sexual, blood, and mother to child, and the physiopathology, as I said, it is played between the immune system, the CD4, the lymphocyte T CD4, and the viral load, and we have evolution to death. And clinically, there is no specific symptoms, and the WHO and the CDC grade this about stages to understand well the opportunistic infection going through it. This is from the Haitian Ministry of Health protocol. So when a person has HIV, after a CD4 less than 500 or with a stage 3 or stage 4 disease, you are eligible to get ART. But since July 1st, they changed it from the WHO new guidelines, so everyone has to start out. And what we start is with the tenofovir, lamivudine, and efavirenz. This is the first line regimen here over there in Haiti. And then after, if they need to change, they need some combination with the class of choice to get some combination. We have also the second line, but for the third line, we start to have some medication. But it is a big issue because we don't have medication for all the people. So that's why there is a committee at the Ministry of Health, a central committee. So if you need to put people on the third line, you need to send the record to the Ministry of Health and wait for approval. And this can take some weeks. And so for the origin of HIV, for the pathway of this, after some studies, they believe, after some genetic studies, they believe that HIV came first from Africa. And then HIV kind of had a connection in Haiti and to go all over the world. It was because in Democratic Republic of Congo in Africa, after their independence, the United Nations wanted to have some professionals, some French-speaking professionals to go to develop the Democratic Republic of Congo. And at that time in Haiti, we had a strong dictatorship. So a lot of people tried to leave the country, and they find a good way to live to go to Africa. And then after, they think they might contract HIV over there. And then when they come back to visit family or after work, they may come back in Haiti. And at this time in Haiti, we had a lot of tourists over there. So we had some sex workers or people leaving the country to go all over the world, especially in the United States. So they believe from some genetic research that HIV comes from Central Africa, go to Haiti, and to Trinidad, and then after to all the world, especially USA, Canada, and etc. But this is a controversy, so they published some article about it to publish it, and then Dr. App, the director of San Quisqueya, where I work also, with some researches, with some collaborators, is kind of answer the question, answer about each ideas that Gilbert gave. They said that what you see, they proposed a geographic sequence in time about HIV. But PAP and other collaborators, they say that retrospective testing of Haitian blood samples from 1970s failed to identify a single case of HIV, and no cases were traced back to the thousands of Haitians paid to donate blood to Americans during that era. Because at this time we had also dictatorship. We had two major things. There were Caribbean blood takers. It was like an industry. They took some blood from African, from Haitian. They paid them, and then they sent this blood with bad condition of hygiene here to the United States to get transfusion. And then also there is some other things. With the dictatorship, there was some soldiers called Tonton Macoute. They were working for the dictator, so they were killing people, send the dead body to the Caribbean or to the United States or to Canada for medical studies, for medical use. And then after they came, they could like keep you, kidnap you, and take your blood and send it out to other countries in the Caribbean and in the United States. So they believe this situation might be one of the risk factors for the rapid spread of the HIV throughout the world. So as you can see, from the beginning, Haiti was always in the center of the world about the HIV history. We can continue about it. So they were discussing and response. We will have the presentation after, so we'll have time to read a little bit because it's a little bit long and I have less than 40 minutes to finish. So the HIV epidemic, it was in 2014. The number of people living, thank you, the next slide. Thank you. So what is in the world, it's about 36.9 million of people. And in the sub-Saharan, 25 million of people, and in the Caribbean, 280,000 of patients living with HIV. And it's a kind of about in all the world. Death due to HIV in 2014, 1.2 million, with 790,000 in Africa. And about 5,600 new infections per day in 2014, 66% in sub-Saharan Africa, and a lot of them less than 15 years old. And with the adult, we had 48% of women and 30% of young people, 15 to 24 years old. About 51 people living with HIV are aware, they believe that about 51 globally are aware of their status. So we need to improve our way that we do the test, we do the counseling and testing for every person. The HIV in the Caribbean, we have about, as we saw, 280,000 people living with HIV and 13,000 new cases with a lot of death. And HIV is one of the leading causes of death in the Caribbean. So as you can see, some countries with the red color, they believe that infectious diseases, mainly HIV, may be the leading cause of death, especially Haiti and all the island of Hispaniola share with Haiti and Dominican Republic. Haiti is the most country affected after sub-Saharan Africa. And we had our first cases in 1980. They didn't understand what happened, but they started to have some people with diarrhea, with a lot of skin lesions, like they believe that it was Kaposi sarcoma, and some opportunistic infection from what they couldn't understand. So that's why in 1982 they founded Quisqueya Center. Quisqueya stands for a group of Asian study of Kaposi sarcoma and opportunistic infections. Well, it's been used since 1982, so right now I'm working there as a technical coordinator. And it was the first HIV clinic in the developing world, and they are doing a lot of research, and right now this is the biggest Caribbean research center on infectious diseases. And they did a lot of research in the beginning about clinical presentation and risk factors. So as we said, in 1982, we had the 4H Club. And New York Magazine said that victims have been fired from their jobs, driven from their homes, and deserted by their loved one. And any homosexual or any Haitian has become an object of dread. In Haiti, particularly in 1981, you see we have 70,000 of visitors, but in 1982, 90,000. Because they were afraid of getting AIDS, going to Haiti. And in 1985, we have the test by Dr. Gallo, and we saw a rapid spread of HIV among the male who have sex with male. Haiti is the Caribbean. The Caribbean population is 36 million, and Haiti is 10 million. People living with HIV in the Caribbean is 280,000, and Haiti is about half, compared to the less than 25% of the Caribbean population, with about 50% of all cases and about 59% of death. In Haiti, we have more than 100,000 orphans due to death with AIDS. So these kids are kind of living with grandparents or uncle or aunt, and you know that the situation is kind of very tough, very difficult in Haiti. Sometimes a woman cannot take care of their own kids, and she ends up having some other kids to take care of. So this is a big national public health, if I can say that, issue. This time kind of show you, so this is the half, the right half is Haiti, and the left half is all of some major countries in the Caribbean. But if you see some other country like Bahamas in blue, Trinidad and Tobago, Dominican Republic, and less Cuba, we have a lot of Haitians living there too. So if we do some research about people having HIV in other countries, we could have more of this, because there is a lot of Haitians leaving the country for a better life. And as we said, the key fact is 1.8% of prevalence, about the 15 to 49-year-old, but globally is 2.2% of prevalence, with 19% about the male, in the male who have sex with male population, and 8.4% for the sex workers. So it's a big issue, public health issue in Haiti, even though we do the testing for everyone. For example, in every hospital in Haiti, what we are trying to do from the Quisqueya model, we are trying to replicate this model everywhere in Haiti. So people have come. You may take a taxi to go to the hospital. So every patient who come in, we offer them the test. And sometimes we offer them to call the taxi driver to come in to get the test. For example, if you go to the hospital with a family member or with a friend, they offer the test and they offer the family member, they offer the friends. And sometimes in Haiti, to get the vaccine, the mother might send the baby with a godmother or grandmother to go to the hospital to receive a shot. They do the test, and they do the test for the caregiver or for the person with the baby. So we're trying to have the test for everyone, but at this time, it's still a big issue to get these two groups. The male who have sex with male, because in Haiti, people are afraid of telling about their sexual orientation. And you know, about some months ago, we had some demonstration in Haiti telling that like God create a man for a woman, so it's kind of socially they don't understand the population is not well educated. So when they are not well educated, they cannot tolerate every person. So they kind of throw rock to them when they saw a gay man in the streets. And with the sex workers, it's very difficult also because they operate in the streets, they go on the streets and sometimes without protection. Sometimes they do it just to have some food. So the person, the guy who comes to them, if he doesn't want to put condom, he might know that he has HIV. So the lady, she doesn't have to do something, she just do it just for the money. The prevalence for per sex and age, we see that about the age, and as you tend to be in the middle age, the workforce, there is the major group with HIV disease. This is, I'm sorry, there is some slide in France. This is the prevalence based on if you are single, married, or living with someone, divorced, or widow. Did I say it well? Widow. Thank you. So with the single person, you know that the single person, they are young, so they already have some condoms, so they know about it. With people in union, you started to have some the prevalence is about low, but with the divorced person, because if the person is married, it's kind of forget about using condoms, and after divorcing, the group is, this is the risk factor of on this region. They kind of advocate about it because Quisqueya has a center over here, and we are kind of studying about if they say the truth, but we don't know where and how they found this data, but it might not be true because we have a lot of people testing the prevalence is lower than that. In Port-au-Prince area, this is the western department, and this is the Port-au-Prince area, because in Port-au-Prince is the capital. A lot of people leave the rural area to come in Port-au-Prince to get job, to get new life. So Port-au-Prince is kind of the capital of Haiti, but it's a huge slum city. And after the earthquake, this is one of the major cities with the earthquake, so we still have 10 cities after more than 5 years. So people live in bad condition. You see, there is a lot of group of people with HIV. This slide shows, sorry, it's in French, but this is the prevalence based on socio-economic situation. The first part is the religion. You can see Catholic. Without any religion, prevalence is 4.1. Catholic, 2.9. Protestant, all group of Protestant, Voodooism, 7.5. As I said, some people, when they are sick, they might have money to go to hospital, to go to private doctor, but socially they believe that the voodoo priest is able to heal them. So they go to the voodoo priest, and voodoo priest take big money, a lot of money from them, but he has sex with them because he explained to them, if I have sex with you, the spirit that is in my head will drive to your body to heal. And I can say that because I know a lot of them. We have programs with them at Quisqueya centers, a lot of photographers who are HIV positive. We have some programs with them to tend to change this situation, but you know, people can do a lot of things in front of money because it's informal. There is no regulation for this. What we have also, this is the where people live in the camp city after the earthquake. It's 5.7 compared to the urban, rural, other cities, all the Port-au-Prince area. So it's because in tent cities, there is a lot of rape cases and a lot of bad things going on in these areas. The two major groups, the MSM, Hausa in French, MSM group per department, you can see very high, 29% in the north and east area, and with the sex worker, 88% in the central department of Haiti. But this is the two major groups with a lot of HIV that we have in Haiti. Consequences of that, so you understand well, based on all what I said. Demography and health, we have a lot of mortality, and the life expectancy is kind of decreasing because a lot of people is dying with HIV without care. And when they die, they leave kids, they leave wife without good condition, they leave husband without good condition, and this is a big issue for the population. Sex and age, we tend to have AIDS in the young part of the population. And with the sex, the women, we have HIV more in the women. It's about 159 women per 100 men. Society and economy, so household, it is a big issue. There is no family in Haiti because you can find a lot of families, someone died with HIV, so there is a lot of people coming to uncle or grandparents' house, and it's difficult to take care of them. So it's a big issue for the health system because the health system is not well defined, it's not well organized. And also they can have, they cannot take care of all the people. In agriculture or enterprises, you know, the first work, the group of first of the population, the youngest, they are sick, so they cannot work every day. They have to go to hospital. And maybe naturally there is no work. So a lot of people are unemployed. In economy, there is a big impact on economy. But the huge factor is the women. We compare Haiti like Africa. This is from UNAIDS from Africa, but this is the same situation as Haiti. The woman is the central. The woman is giving birth. The woman in Haiti is still compared like inferior to men. So the man is the big master of the household. So the men can have like 20 other women, but the woman who is in the house is still in the very low position. So the man can have sex with everyone and come to the house. And the woman is giving birth. The woman, like we can say, from the young person who can afford a good condition of life, they kind of having sex for money. So this is a very huge situation, and this is something that they wrote about Africa. I found it, and based on our research, is the same in Haiti. So women are especially at risk of contracting HIV because of the interplay of that. Based on also on biological system, biologically women are more susceptible to have AIDS. And some physical differences, powerlessness, dependence, poverty, so all of this is played a bad role for women. But since the beginning of AIDS, we had some good actors, international agencies like CDC, PEPFAR, Global Fund, UNAIDS, WHO, European Union, a lot of organizations working in Haiti with some intermediate management structures and some local management NGOs like Quisqueya Centers, Partners in Health, the two biggest NGOs. The state services, about 30% of health centers, public health centers, they are involved in taking care of HIV people in Haiti. And we have some policies, programs and intervention in risk reduction, prevention, vulnerability reduction, impact reduction, human rights promotion, sustainability, that we want to have surveillance, monitor, and evaluation. And with this policies, program, and intervention developed through the PEPFAR, the presidential emergency plan for program for AIDS relief. So with this, we kind of developed some model that the PEPFAR program took from Haiti to develop to other countries like Africa. So in the beginning, it was the best, the bad part of HIV in Haiti, but now Haiti tends to be a model to share this system with Africa, even though the health system, the central health system is very disorganized. But we have a strong HIV program regardless to the Haitian health system because we receive a lot of funds from external aid. So achievement, we have state political commitment, implementation of appropriate management of funds, especially with external support. But we have some support of local governance, especially in doing book, paper to distribute throughout the countries. It's not so many, but they participate. Partnership between private and public sector, competence reinforcement for management and caregiving, and community-based approach. This is the biggest issues, the community-based approach of HIV, and we're gonna see it after. So we had a lot of intervention, care of people living with HIV, and every site they are kind of an empowerment process every day. Information, education, communication for behavior changes, promotion and availability of condoms, STI control, and combined intervention. And we are doing a lot of operational research, especially in Quisqueya Center and in some centers from PIH, Partner in Health. So the fact about Haiti, as I said, the prevalence is 2.2%, but the prevalence tends to decrease from 1980 to 2010. And the number of living with HIV also is kind of decreasing, and also number of new infections. This is the number of tests that we realize every year. You can see from 2008 to 2013, the number of screening tests that we are tend to increase, except in 2010, we had a big issue, the earthquake that we had. Percentage of men and women. In yellow, this is the women. In blue, this is the men. So men, they're like, in Haiti, they think they're strong, so proud. So if they're sick, they don't want to go to hospital. Compared to women, from the first sign, oh, they want to go to the hospital. So men is kind of, before death, they go to the hospital. This is a cultural situation. This is the number of cases reported, the cumulative number of cases reported from 2001 to 2014. And you can see that it's tend to increase year after year. Per age, the number of cases per age, you have the major from 30 to 29-year-olds, but some major from 25 to 49. This is where we have the major group of people. And the treatment is not static, and you know that we started with one drug, and now we have triple therapy. There is long-acting agents, single dose, and it's kind of improving every day. And I know in the United States there is a lot of improvement in compare with Haiti, and you are allowed to share just after the presentation. The new infection cases, they're kind of decreasing compared to 2010 and 2015. So the new cases are decreasing over the years. And also, this is the same thing, people living with HIV, they're decreasing over the years. This is the percentage of people death due to old age, so it's kind of decreasing. This is kind of the same. The challenges that we have in Haiti, because you know we don't have a strong health system. So for health supply, we receive medication from the United States, from money from the EU, from the contributor in the United States to perform programs for more than 90%. 90% of the money that goes to Haiti comes from the American contributor to taxes. And then we receive about 8% from the Global Fund through USAID, and we about 1% from other agencies, and less than 1% you're gonna see it from the government of Haiti. So health supply, we have a big issue with the antiretroviral supply. Between testing and treatment, there is a lot of gap in these cascades. They start to treatment very late. Sometimes they don't understand, or sometimes because before you had to have some CD4 less than 500. So in the hospital they might have not good physicians. They don't take into account the clinical stages, so they are waiting for the CD4, and sometimes in a region you cannot have laboratory. You have to send the sample to another city to have the CD4, so waiting, the person is kind of progressing with that bit. The major issue that we have is the adherence to the treatment intervention. As you know, the people in Haiti, they are not well educated. They don't understand. Sometimes I personally talk to them and then they say, well, doctor, I stopped with the treatment because now I feel well. I said, no, you don't understand. I said, yes, I understand. But I said to them, this is my body. I feel well, so I don't need the medication. But after they came very ill, they come back very ill, and when they come back, we start the medication, it's like a ping pong. So we need to have a strong program. We need not also the health, the HIV program, not only the health system, but all the system, education, social, everything in Haiti has to be better to have a big program. Human resources, as we said, there's still brain drain, and I have to say to you that it's been 3 months since year that all the public hospitals in Haiti are on strike. All the public hospitals in Haiti. Only the private and NGO clinic works because the doctors who work in public hospitals, they want their salaries to be increased. So when I say strike, no emergency room are allowed. When I say strike, all the doors are closed with some chain. I don't know how to say cadenas. The thing
like
that they lock
like a lock.
They locked it, and nobody will know where the keys are. And if you tend to unlock it, you will see some people end up and give you some, I don't know, beat you to go away. Because they want the government to do something, and you know, we are kind of in a transitional government. With the transitional government, there is no international help, no international money. The United States especially send out of that, sends this. So it is a big issue, so people tend to go to NGOs, tend to go to other things. So, and I can tell you, yesterday I was talking to a friend of mine. He's an orthopedic in Haiti. He said that I am, how can I say, je suis fatigué. I'm exhausted with this situation. I'm going to leave the country with my family. And he's not the only one. So fund management and technical support, this is also a big issue in Haiti. This is the major challenges that we have. If we look at the cascade, for example, if we reported 100 of cases, this is from the Quisqueya centers, from what we have. For 100 cases that we have, 79% are enrolled in treatment. For example, if we at an hospital, we have 100 tests, people tested, only 79% go to the system to get care. Because the other, they are not well counseled, they are not they don't talk well with them, so they don't understand. 62% have a CD4 test. 52% are on heart. About 50% are about CD4 less than 200. So we're kind of losing patients in every part of the cascade. Compared to the PMTCT for the Quisqueya network, this is not for all the country, it's for the Quisqueya Centers Network. This is the group of pregnant women tested, and this is the cascade. Enrolled in care, go to medication, and this and that testing for the kids. You don't see completely, there is nothing. So it's a big issue for PMTCT, prevention of mother-to-child prevention. Our big issue also is the money, and you know that we are funded by PEPFAR, and from the year 2004 to 2016, this is the million of donors that we received, and from 2011, it kind of decreasing year after year, but we're kind of having more patients. So we have to do more with less. And this is how the fund is. 99.72% of the money is from external and 0.28 from the local government. So if all the countries say we are not going to give anything to Haiti, we are going to. I'm not going to. I don't know. So you can imagine. For the country operational plan 2016, we had 390 to achieve it. 90%. This is from the platform. They kind of give us this. If we don't do this, they are not continue to fund us. We have to test. 90% of people getting tested have to receive their post-test counseling, so they have to know about their status. 90% of this group of persons has to be on treatment, and 90% of this person have to have an undetectable viral load. And we have to achieve this goal no later than September 30, because we're gonna have next year in October. So to do this, what we do is the target testing. Target testing. We go to key population. In Haiti, it's like a big wall. Even though all the public hospitals are closed, it's like a big wall. We are looking for people with HIV to get the number increased so we can have more money from the CDC. Because the CDC representative, the big head of CDC, in Atlanta here, she said, if Haiti doesn't give big result, they're gonna cut the fund. And if you cut the fund, we cannot imagine what we're gonna go through. So we're gonna have a lot of things done, go to the prison, go to the key population to have the test done. For the second 90, giving them medication, we're kind of giving every people medication. And the National Alliance of State Director of AIDS, this is a national alliance here in the United States. They work also in Haiti, so they kind of develop a program to trace patients. So you can see this is 13,000 patients to go through, 13,000 patients with HIV that we have lost, and we have 7,000 that return to the clinic. And even though people are returned with this community, this is a community program. They have a lot of community agents they send to the community. But even though they send them, we don't have a lot. It's a very small group for all the people that we have for all the countries. But they do a lot of work, and with this work, even though they receive the patient, they lose the patient after. And the reason that the people give why they quit continue their care to the clinic, 38% say that they forget their appointments. We don't know if it's true. 30% of them, they said that there is transportation barriers. We kind of putting some sites next to this house, next to their house, and you know, the fund is decreasing, so we have to close some site and keep some major site and transfer the patient. So there is some problem with transportation. Money to take taxi to go to the clinic, it's a big issue. And 15% say they were too sick. So if they are too sick, that means they spend a lot of time without going to the clinic for the care. So we are target the patient-centered intervention, and we go to community. We kind of doing community distribution of drugs. So if the patient cannot go, we go to the patient. But unfortunately, we don't have enough health care worker, enough community health officer and agents. And what we developed again is the rapid pathway. The rapid pathway, because people, when they are at the clinic, they spend a lot of money, so we kind of reducing this time from 2 hours to 30 minutes. So what we do, if we know that we will have 50 appointments tomorrow, a nurse calls all the 50 patients in the afternoon, and there is a form that he checked. Are you okay? Do you feel something? Do you feel something like that? And if the questionnaire is good, she just prepared the medication and she said to the patient, when you come, you have to go to this room or that room. And when the patient comes, they just give the patient the medication and the patient goes. And they give appointment for 3 months. Except if the patient has something that requires to see a doctor, they send it to a doctor. but we kind of doing it quickly so the patient might not spend a lot of time, so it can have adherence and retention to care. Progress to the third 90, we just start with the viral load treatment because we didn't have enough money and enough material to have viral load testing. So we kind of testing it, and we want to have this test for all the patients to see if the viral load is decreasing. So if we don't attend this after September 30th, we don't know where we will be in Haiti. The perspective with the challenges, we know that there is political turmoil, natural disaster, a lot of problems with Haiti. But even though the response to the epidemic, the prevalence is getting low, the number of people living with HIV on ART are increasing, and we have a lot of publication, a lot of research. And the key components of this is everyone gave their effort, the international community and the national community. So it's like everyone is involved. When you go to the hospital, in the HIV program, it's like every nurses, every doctor compare the program as its own business. This is my business, even though they don't pay well for this, but they do some training for them, so they are really involved in this. So we need to do something about the cascade in order to not losing patients. We have to work on retention and adherence. We have to work on early detection of treatment. We have to go to key populations, even though it's easy. And we have started to have some work with the male who have sex with male, even though it's difficult. Sometimes myself, I go to them, and to talk to them, they are so afraid they invite me to the bedrooms. I can be like a woman, half of this with about 20 male who have sex with male, and they have HIV, they have tuberculosis, and it's very dangerous even for the healthcare workers. Because sometimes if the population know, they might come to this house and burn it. They done it one time in Semor.
Yes.
And we have to do on the integration of prevention, screening and treatment, the TB HIV integration, because you know that we have a lot of TB cases in HIV patients, training and research, economic and social, and we have to do more with less money. And we are kind of yelling at the Ministry of Health to get more implications, especially financially. So what to do and how to do it now, we don't know. We are like comparing the Asian health system with the Asian HIV program. The Asian HIV program cannot replace the Asian health system. We have a strong HIV program. We are proud of it. And we from this model, we replicated, the CDC have replicated this model to some country, to Africa. And in this country, the government gave a lot of money, so it's kind of empower other programs. But here in Haiti, with some good example, we are still very bad with the Asian health system. So one of the things that we do is partnership with a lot of institutions. And in this partnership with NW4, we remember, as I said, the major problems that we have is to have the community agent, to go to the community, to have the people getting the medication, to bring them back to care. So this is what I am very honored to be part of the team of the global health system to create a big program at Université Quisqueya, a program for community health officer. So in order to improve health in Haiti. We are working together for many years and all of our work is based on social responsibility of medical education. We have training programs in Haiti, and here we have 2 symposiums, and every year research activities that we are doing together. And our research is not doing research for doing research. We take the students, we go to them with Dr. Kalshi. You can have some photos in Dana, Dr. Zervos. They go to the community with the students and show them how to do research, how to collect data, and how to understand them. And we have some strong community actions, because with this data, we can do a lot of changes in life of patients. So in this presentation, I want to thank you all at NW4 Health System for all you've done in Haiti. Before before ending this presentation, I want to invite you all in Haiti on December 12th to December 16th, because at the Université Quisqueya in Port-au-Prince, we are taking a museum from France to have it for 1 week in Haiti, and it will be about the heart of heal in traditional Africa. So we are kind of, it's the role of the social accountability of medical education. We are kind of meeting with all the priests, the voodoo priests, the traditional medical in Haiti, and show them what they do in Africa and talk to them about community health, what to do to improve Haitian health system. I didn't say all the things that I had to say, but I think with this presentation, I show you Haiti as a little girl who is suffering, but who still have hope. Thank you.
Dr. Dunbar, I want to thank you for a wonderful presentation. Very inspiring also presentation, and it is shows all of us again I think the importance of working together with our neighbors and considering ourselves a global community, and it also emphasizes the importance, and HIV is as good an example as any, the importance of building partnerships, and Partners in Health was of course a great example of that between Harvard and workers in Haiti and Quisqueya with Cornell, and also in Haiti. They were just fantastic models, and one of the reasons for us on a much smaller scale getting together is to still look at opportunities to build on what we've been doing in Haiti together with you, because those partnerships are very important, and the work that's been done with HIV in Haiti it's been fantastic. It's been a model to others, and especially what Quisqueya has done has been it's a model for what we should be doing in Detroit, I think, in some of the things that we're doing. But we'll open it up for questions and comments.